So the first case is a young man in a rural community consuming alcohol, falling off the back of a moving utility, a very Australian thing to do. He was found at the scene 20 minutes later. Why 20 minutes later, I don't know. Initially a Glasgow coma score of 9 out of 15. He was intubated because of the fear of vomiting and concerning his airway. Transferred to a Metropolitan Neurosurgical Unit. CT scan done as reported there, so a serious injury, but not the sort of injury that one would really expect would result in death at this stage. I should also mention as we present these cases that if you're sitting there thinking, oh, I know this case, you don't. And the reason you don't is that they're nearly all from interstate, and they have been an amalgamation of several cases, so you won't recognise the true cases, but I'm sure you'll recognise I've seen a case like this before. Okay. So he was ventilated overnight, taken off the ventilator. He was extubated, found to have a Glasgow coma score of 14, so he improved considerably. Neurosurgical team were then able to assess the patient, but they hadn't been informed by the intensive care unit of his admission or indeed of his transfer. So this was about 30 hours after the injury and about 24 hours after his admission. Sent up to the neurosurgical ward. The case note suggested that the observations were no more than 3 hours, so that's the assessor could only find 3 hourly observations. At 10:20, there is an observation, a formal observation of Glasgow coma score, another one at a time that is not clearly recorded. The next observations were at 16:15, so some 6 hours later, suggesting there was a 3 hourly observation being performed. There's no written record of how often the observation should have been done, and there was no record of any communication between the senior and junior medical staff, and indeed with the nursing staff. So there was a part 3 to this, but I might just pause there, Guy, and let you handle it from here.
Well, George, this sounds like one of your patients. Can I ask you just to sort of speculate on how much would have this case been better managed if everything had been written down, or if Santosh would tell us it's all written in the electronic health record? Would have that actually made a difference, or do you think this was something that had nothing to do with the documentation?
No, I'm sure the documentation is very important, but as Cheryl was pointing out, the documentation and discussion are complementary and sort of go hand in hand, but I don't think that we can blame the deficient documentation entirely for poor patient care or poor patient outcome. I mean, it goes right back to when the patient was transferred. I think that the patient was transferred because it was felt that he had a significant neurological injury, probably did, and required care not just from intensive care specialists who would be good at managing his airway and looking after his circulation, but also required care from a neurosurgical team. So that should have been part of the initial task, in my view, that when the decision was made to transfer the patient from wherever it was in the country that the injury occurred, that should have been done in consultation with both the neurosurgeon and the intensivist. Now I don't think we're in the business of pointing fingers and blaming here, but anyone, either the GP in the rural location or the intensivist that accepted the patient, could have taken the initiative to involve the neurosurgeons. Now the value of that, as Glenn would appreciate, would be that they would have had a plan of management and observation delineated. Now whether that would be documented or not is another matter. So there needs to be documentation, because if there's no documentation, there's no defence. I'm sure our legal colleague will attest. And not only does there need to be documentation, but hand in hand with that needs to be communication with the appropriate people who are delivering the care. And in this case, it's not just the intensive care, it's also the neurosurgeons.
But Santosh, this probably was spoken to the intensive care registrar who was on. But by the time the patient gets transferred, a typical transfer in South Australia from one of our regional centres is not less than 6 hours and often longer. By the time it arrived down there, of course, the neurosurgical cover had gone home, the ICU reg had transferred across, and so there was no information, despite the fact that it probably had been appropriately transferred to the staff who were on. I mean, does this happen in your unit, or have you got that sorted out?
I mean, from our perspective, generally what we do is, as soon as we receive a call, the question that we ask ourselves is who needs to be part of the decision-making process. If it's a trauma coming in, is it a chest injury? Should it be cardiothoracic? Or could there be further injury? But once the patient arrives, what we do is we go through the entire process of getting a CT scan, getting all of that done, because it changes once the patient arrives. Sometimes people say that they have had a chest injury. It might be just a small bump to the chest, but the major injury may be the head. And at that point, yes, I completely agree that we should probably have allowed we should have let the neurosurgical team know. But it looks like the patient was extubated in the afternoon, and the patient had a GCS of 14. To have severe cerebral edema with a GCS of 14 clinically doesn't make sense to me. So it's probable that over a period of time that the patient developed some sort of a secondary injury, hypoxia or something like that, that made the patient have worsening cerebral edema. But also there was this issue of when the patient was transferred to the neurosurgical ward, what was the expectation? The expectation would be there would be clear communication from the intensive care of how often should GCS be done? What happens if the patient's condition deteriorates? Who should be called? All of that should have been documented into the notes.
So do you think these sort of things would have been better managed maybe by a protocol that says all neurosurgical patients will receive hourly OBS until the orders countermand? Or is that a way to stop this lack of communication occurring, or are protocols fraught?
Often what we find with protocols is that it's good to have certain level of protocols. Like there was a very interesting study that was done. The more junior you are, the better protocols work. As you go higher up, protocols actually hinder communication and how information is transferred. So it is important that teams have protocols, but also communicate.
So do you ever follow a protocol, or just make it up as you go?
I think protocols are good. I mean, I think that we know they work well. This, unfortunately, is very depressingly almost the exact reading of a case that I was involved in 1989 when I did a locum SHO job at Hope Hospital in Salford. And it almost reads word for word exactly that. And it really is that importance. If that delayed edema can occur and they can die from it. And the question really was, the good news was at least the patient was transferred to a neurosurgical ward and not another ward. But it does look like there was poor communication between the ICU and the neurosurgical team. Or at least the neurosurgical team, when the transfer occurred, there hadn't been clear instruction about the timing and that of observations.
So does this all fall to nursing? Or is this the only way we're going to make these sorts of patients not fall through the cracks?
I think, so there's a couple of things here. Transfers out of the ICU, we know are, especially around after hours, are fraught with danger. We know the outcome for our patients who are transferred, outside of business hours is quite poor, and the need to actually have that close communication with the ICU following up these patients has proven that patients do have a much better outcome, and that's because the ICU nurse can actually be at the bedside and give the nursing staff who may not be familiar with a protocol or an expectation, they can sort of talk them through what they would see as fair and reasonable for that particular patient. With regard to neurological observations, there's certainly been war and peace written for nurses on how to go about doing an assessment and documentation and how to escalate. And there's an area where I think in nursing that is of huge concern to me and to many others, where the adoption of, our between the flags RDR charts has not actually decreased the risk for our patients. I think in many cases it's actually increased it. And we see this all when, many of us who are sitting on incident review panels, etc., we will see the observations beautifully documented, exactly the same way they used to be pre-RDRs, where people have actually stopped thinking because they're told if it's not in the red section, don't call for assistance. If it might be in the orange, and the nurse goes, actually, I'm not happy where this is going, but if I call a Met at this stage or escalate this, someone's going to say, don't worry about it, it's okay, it's all within what is acceptable and normal. And I can see lots of heads nodding out here because many nurses actually have these experiences on a day-to-day basis where when they actually raise concerns, they can be questioned, especially if it's a grumpy Met team or MER team that comes out, what are you doing? On the flip side, the nurse who actually makes the assessment that, yes, I know they're in the red section, but the home team is 2 beds down and they're coming, the patient's completely stable at this stage, and I'm not going to call for additional help, can also find themselves in a bit of a sticky situation when someone does an audit on the chart and goes, hey, hang on a minute, we're in the red section here. So I think, going back, looking at protocols and looking at expectations, we need to remember that these are guidelines and we still have to encourage our clinical staff that are at the coalface to be critically thinking about what they're doing. So what does that blood pressure mean? What is that heart rate? If a patient has a head injury and they are sleepy, who am I going to tell that to? I'm not just going to document it on the computer or in the case note. I actually need to go and have a conversation with someone and actually say, hey, can you come and have a look at this person?
I've gone on to the next slide.
Before you do,
Yes.
Cheryl, I was going to ask you, that comment that's just been made about going and have a talk to someone and I'm concerned about this patient, when you get the case 4 years from now to deal with it, none of it's documented, and you're going to turn around and say to us, as you always do, if it wasn't written down, it didn't happen. Yet, we've done exactly as Diane suggested. We've gone out and tried to engage in a communication, and then the things escalated and never got written down. How do we deal with this?
I'm not sure how you deal with it. That's very, very difficult. It is true, if it's not written down, it didn't happen. But there are buts associated with that. And in this particular example, and what you said, Guy, about this happens 3 years later by the time it gets to me, and that's probably right. But there certainly are circumstances, and if we use this as an example, where someone may well remember, because this was actually extraordinary. And although it gets to me 3 years later, usually it's hit the hospital investigation stage much, much earlier than that. And sentinel things that happen, people actually do remember. So it's really about documentation is absolutely ideal. If it's written down, I went and discussed with X, I communicated this with the doctor, that is gold, and we love seeing that. But if it's not written down, it doesn't mean that the wheels are going to completely fall off. There are always challenges. The legal test is, well, was that management reasonable at the time? So often people look back with the benefit of hindsight, knowing the outcome, and say, well, that practice wasn't reasonable. I can't believe you didn't transfer this patient. I can't believe that, someone went, I can't believe any of that. They're looking at it with the benefit of hindsight because common things happen commonly and extraordinary things don't, which is good. So I think I've probably given a bit of a rambling answer, but the answer is if it's not documented, doesn't mean that you're not going to win or you're not going to be able to defend your positions. If you actually can give evidence, explain precisely what you did because you remember it, and there's a good chance the person you spoke to will also remember it, and it's even better if the memory is, those two independent memories are actually consistent. So that's sort of what I was going to say. A bit about protocols. Protocols are lovely, but they're not the answer. there is no replacement for communication. And on something like this, you know, it is really important that the handover is appropriate, that the nurses need to understand the impact of what it is they're actually reading. It's all very well to do the observations, but if you don't actually know what to do with what you're observing, whether this is okay, not okay, people need to be empowered to ask questions.
Before we move on, George.
I just wanted to reinforce a point that Santosh made in one of the slides, that protocols are a little bit like the sort of things that we do, mental shortcuts, heuristics. You know, when did you last think about walking? Your cerebellum does that for you, I think. You know, it's the sort of coordination that's brainstem. You don't think about walking. So at a very junior level and at a very simple level for managing routine events, protocols are terrific. But when it comes to more complex situations, the flip side of that, the two-edged sword of it, the point that he made was that heuristics are your enemy. If you're shortcutting because you know better, that is your enemy. So you have to stop, take time, think, draw a breath, say, now it's time for station identification, which is what I do in sort of the operating theatre context. What is going on here? Stop, do nothing, hands down, wait, identify everything, then move on. That is the way I deal with it. So.
Go ahead, carry on.
So I put up what actually happened to this patient, and you can see that in the first paragraph there, the recordings of the GCS are really pretty inaccurate. They're not according to the classical coma style. There are observations such as confused time, place and person, alert and talking, but no formal GCS. And unfortunately this progressed downhill. The other point in there is that the CT scan was performed. It was noted that the cerebral edema was worse, and as Santosh suggested, maybe it was a period of hypoxia, and yet this was not transmitted from radiology to the treatment team. So this patient died 28 hours after being recorded with a GCS of 14. Now, okay, so 4 cases. 88-year-old, comorbidities, no advanced care directive. 93-year-old, seriously ill, has an advanced care directive saying no aggressive treatment, has a perforated colon from a recurrent carcinoma, family want maximum treatment. 73-year-old, severe brain damage after a stroke, advanced care directive exists, but it's been lost, nobody knows what it says. One estranged son wants palliation, daughter wants maximum therapy. 66-year-old, 2 months after severe head injury with minimal recovery, no advanced care directive, no immediate family members, one part of the extended family who's set to inherit in the will wants palliation, and the remainder do not want palliation. All these cases are actual cases, they're not made up.
Well, yes, I mean, unfortunately, they probably occur to us all on a monthly basis to one degree or another, and I think it probably in Santosh as well on a daily basis. I guess the issue here is, the 88-year-old with multiple comorbidities and fractured NOF and no advanced care directive, this is the sort of thing you're going to see, Santosh. How do you manage this patient when confronted with them? What are the steps?
In fact, you're right. This is almost things that I see all the time. And often what I realize is that families, when you walk into the room, the first thing they think is he's going to say he wants to withdraw. And they are already preparing for battle. And you walk in there and you start by having a conversation. What do you mean by maximum therapy? Is maximum therapy putting the patient on ECMO? Is it going in for cardiac surgery, doing all of this? This is maximum therapy. But is this what your mom wanted? Begin to bring the patient into context and ask, what is it that your mom would have wanted in this situation? Very quickly what happens is it becomes a question, the question of you against me is the thing that needs to be taken out of the room. What I often find is when we start focusing on the patient, and slowly telling the family, I'm actually on your side. I actually want to do the right thing by your mother or your father. They usually start turning around. And the second thing that I realized is everything doesn't happen in the first conversation. If you walk in there thinking that I want to come out with a clear answer about yes or no, often you're frustrated and the family is frustrated. Or it may take a few conversations because it's difficult for them to come to terms with something as difficult as their mother or father dying. And what I found is to leave it over a few conversations. The other thing that I have often found is that in difficult situations, that's when the maximum family conflict occurs. And often you need to understand what the conflict is within the family before you start trying to give people a whole lot of advice. And a few of these principles, when I have started using, I find that it's much easier to get people to come to terms with. The other thing is that in intensive care, we find that other departments make up their mind of what is maximum therapy, even without involving us from intensive care. It's like telling the surgical team, without involving the cardiac surgeon, to say, I think it's okay to have heart surgery. You can't say it's okay to have ventilation or tracheostomy without involving us. So it is better to get us involved, and we are encouraging teams to get us involved early.
But if we take the example of the first one, the 88-year-old with multiple comorbidities and a fractured knob, we know the longer we wait, the worse the outcome. So if you are going to get the best possible outcome for this 88-year-old, you can't have 10 conversations. You need to take him to theatre now or give up. But, making the decision 24 hours from now is not going to be in that patient's best interests. So that is where the problem, it gets very difficult, because the way it's been presented here, you would think, well, really we shouldn't be doing anything. But, we don't normally execute people with dementia, and yet we're proposing to do it. George?
Well, surgery is sometimes a good palliation, even if only for fixation of a fracture like this so that the pain is relieved. This sort of thing can be done under a single shot spinal. In a couple of hours, they're back in the ward, they're pain-free, and then they might die a week or so later. I don't know that we're aiming to cure it here and get them to hospital.
Diana, this is obviously going to involve the nurses a lot, because they're the ones who are going to have to deal with it. We'll come in and operate, that's easy, and then we'll be out of the building. But the nurses will be left with the grief, the consequences of our decisions. How do we communicate that?
So I think there's a couple of things here. When Santosh was talking about discussing, having the gentle discussions with the family. Now, these don't need to go on over a 24-hour period. Sometimes it will be a 5 or 10 minute discussion, walk out for 10 minutes, come back in and recommence it. And during that time, it's not uncommon for the nurse at the bedside, especially in the intensive care, to actually be explaining to the relatives what all the different terms mean and what the reality of it is. And so they actually do play a really important role in making sure that the families are really well informed about what their decision will mean in real terms. So do you want your mother to be resuscitated? And we say that, do you want her to be resuscitated if something happens? And they go, yes. And you say, do you actually understand that that means if your mother's heart stops, that people will actually do compressions on her heart? She might get some broken ribs, will actually, have to, keep her on life support. Is that what your mother would like? And they, oh gosh, no, I don't want that at all. So it comes back to, what Cheryl was saying about using lay terms, and the ICUs tend to do this very well in that they play tag team between the medical and the nursing staff, and then the medical staff come back in and have the next level of conversation with the family. That works particularly well.
You deal with this, obviously you don't have many broken legs, but you have people with severe end-stage disease. What's the tactic?
Well, I always try to point out two things. And the first is that, particularly in the public system, people do sometimes seem to think you're wanting to put their relatives down. And I point out to them that I will treat their parent as I would expect my own parent to be treated. And that I think that we need to look at where we are going and what we're going to achieve. And I think there's two stages to that. One is that I say, look, you know, no matter what I think and what we do here, I cannot see, no matter how lucky we are going to be, I cannot see your father or mother leaving hospital. And therefore we've got to make a decision about whether we're going to start inflicting more pain or whether we're going to shift the care. We just need to recognise that you're elderly.
Is there a chance? Is there a chance?
No, and I think, and you're quite right, this is the bit I think that we're very bad at doing. I think we're very bad at allowing people to say there is a chance. And I think we do have to be very firm and say there isn't. And I think doctors have become very, very bad. And I think this is part of why the escalation of costs are occurring across our healthcare system, is we're offering futile treatments to more and more patients. And I think we do have, I personally think we've actually got to start saying, no, there isn't a chance. And I think the other group that are those patients who are going to get discharged and you know they're never going to be discharged home. It becomes obvious to you very quickly that 88 or 93 that comes into a hospital will almost certainly never get home. And you've got to say to the relatives, you do understand they're not going home. That the best outcome we have from here is from here to a nursing home. And that's usually the bit at which they go, oh, forget that.
I guess I'll pose this question or comment to Cheryl, but I understand that in this state, at least over the last couple of years, we have legal protection that we're not obliged to offer futile treatment. So I think we can advise people, as you said, that this is clearly futile. We think it's not in your mum or dad's best interest to have it. The outcome is definitely going to be bad, and I don't resolve from that. I tell you.
Yeah, that's correct. That's correct.
So, I mean, just to throw it to the audience, give you a chance. I mean, you've all seen these sorts of cases. Do we handle, or has anyone got any suggestions on how we deal with these terrible cases where we're 99.99% certain it's all going to end badly, but you have families who are obviously working out a whole lot of guilt that would be sorted out over several weeks, but we've got to deal with the problem today. Has anyone got better strategies? That's what I thought. All right, well, so we move on then to the next one, which was the 73-year-old severe brain damage after a CVA. There is a advanced care directive, but no one knows what's in it. And as always happens, there's usually a son in New York who wants everything done and who's never seen mum or dad for years, and the daughter who cares for them wants the palliation. I've turned it around on that one, but that happens all the time. Well, I mean, I'm not sure, I don't think any of you can answer it very well, but perhaps Diane's the most useful person to try and tackle this. How do we do it?
Case 3.
No, I'm on case 3 now. We've dealt with case 1 and 2. Case 3, Diane, how do you communicate to manage one side of the family that wants everything done and the other that is ready to bury them?
Yeah, so unfortunately this is not an uncommon occurrence. It happens almost on a daily basis where we have conflict, as someone said before. Severe, catastrophic events bring out often the worst in families, and the conflict comes up and takes precedence over what's actually happening with mum or dad who happens to be lying in the bed. One of the things that I have found particularly useful is, number one, don't get in the middle of it. You need to let them sort it out, but pull in your other resources. So hospital chaplains, for example, are a brilliant resource to bring into the conflicting family. A lot of them are actually crisis counsellors as well, and certainly in the intensive care environment are used on a regular basis to referee.
This patient's a Muslim.
then we would actually call in the rabbi or whoever.
The rabbi would not be much help either.
Sorry, not the rabbi. The mufta. Yeah, mufta. And that's not uncommon actually. So regardless of what your beliefs are, we all hospitals have a running list of the local who's who in chaplaincy, and we do pull them in. And the other group here that we do pull in as well, of course, is our Aboriginal liaison group, and they will actually activate elders often to come in and referee the families. The worst thing we can do is offer an opinion. So it's not our job is to offer an opinion, our job, of course, is to provide the clinical care for the patient and the care for the family, and to let some of these arguments be dealt with outside of the clinical setting so that it's not actually muddying the waters. Keep them separate.
Could I just add here that sometimes we think that people are unreasonable and this is a common occurrence and that it's a battle. In the many years that I've been in intensive care, I can only, on one hand or two hands, really talk about situations where they have been absolutely unreasonable. Often, these are people who have feelings. These are people who are attached to their parents. And often communicating to them, explaining things to them, you can move them down from maximal therapy to no therapy. And it's handling those issues, and it's not very common that you have absolutely unreasonable families who will not do it. That's the fact.
I think that's right, Guy. I mean, what we're talking about now is actually not something that hits my desk very much at all. You're obviously, can't imagine how challenging it is. Anecdote, my mum's fine. I can't imagine how challenging it is, and we don't actually get even many inquiries on it over our medico-legal advice line. So all of the things, the strategies that you have in place certainly aren't are great, because the outcomes obviously are good, in that I don't end up with any of these problems. And at the very, very extreme end, they're usually not medico-legal problems. They're, how do I deal with this very, very unhappy situation? And at the sort of the last resort, if you like, if it's absolutely irreconcilable, is we would recommend that the doctor ring the Office of the Public Advocate, who are available all the time and are, in our very limited experience, excellent.
We deal with this last case, and it actually, I must say I'd read this before, but I'm reading it again. This 66-year-old patient with no advanced care directive, one part of the extended family set to inherit the will want palliation, which means I would take that to mean is, because palliation is not necessarily execution, it's palliation. The other part of the family don't want palliation, which may in fact mean execution. Well, they don't. But it's severe head injury with minimal recovery, so nothing's going to come of this. But I guess the inference here is that we've got one member of the group who may have a financial benefit, who seems to want less than active treatment, which is really what I think is being said, and the remainder want active treatment. It's a lose-lose situation. Ewan, what are you going to, I mean, this sort of, I mean, I know you don't deal with head injuries, but this sort of thing, you get in severe vascular mishaps, how are you going to reconcile this one?
Again, I mean, I think it's always difficult, and it also depends on, the legalities of carers, etc. But the usual thing is a clear explanation of where things are going to end in terms for the patient and what the outcomes are going to be and what the expectation of what's going to happen, and a realistic and honest explanation of where the situation is going. I think obviously as soon as the financial thing is introduced, I mean, and that's effectively what this case is doing, then obviously a part of the family who are set to inherit in a will, I mean, in my view, if that is their motivation for palliation, and which is implied it is, well, I think ethically that's obviously, you're going to ignore that side of the family in my point of view. And you need to have the proper discussion with the remainder of the family of where this is going. Now that may end up in palliation anyway, but the bottom line is that once financial issues come into it in that manner, that is not part of the medical discussion.
Their motivation is to stop the other one getting the money. That's why, I mean, with this whole case, which was drilled out over a long period of time, do you think some of the problem might have lived in the handovers that were occurring?
Yeah.
Because, I mean, no one knows what was really handed over, but even if one did, there are these, the Chinese whispers are a huge problem here, and people fail to understand the significance of the case they're dealing with.
Yeah, I think that should, but certainly in this case, that should not have been the case, to be honest with you. I mean, it's clearly what was documented, what was handed over, and what you would look for in this case. I mean, it is very surprising. But the story, I mean, and this would be certainly one of the big vascular disasters that I've seen over my career of thrombolysis. And this should be, it is amazing that this isn't a recognised thing. That thrombolysis that begins in a radiology department, that transfers to a ward, ends in an operation about midnight. And that is the inevitable progression of that. And that happens so often that, as you say, that should have been recognised and communicated very, very, very quickly, that this was a very dangerous situation for this patient to be in. Now, in fact, the patient probably embolized as well to the gut, and that was the problem, and maybe it was later that things happened, or when the patient became hypotensive things happened. But this was a very critical, so you're quite right, communication between the radiology department, the vascular surgeon, and him making sure that the nurses were aware of the potential problems, which is with what is now quite an unusual treatment. That should have been clearly documented and made aware. And as I say, that there should have been involvement very early on of relatively senior staff.
George, can I ask you handover? And obviously not specifically about this case, but it seems to me the great challenge we have in our hospitals at the moment is to get a well-structured handover. The nursing actually know how to do it. They do it extremely well. I think we do it extremely badly, and there are patches of excellence, but on the whole, do you think we've got this sorted?
The short answer is no. As we were alluding to in casual discussion earlier this afternoon, part of the problem over the last 30 years is the fragmentation of care, that we work shorter shifts, we don't own the patient any longer, even at consultant level, we don't take responsibility. Often I do a ward round and I ask myself, who is the captain of this ship? Who is making the decisions at the end of the day? And I find that even at my level, I'm absolving myself of the responsibility of making day-to-day decisions, and that's probably not good. So I haven't answered the question. Make a comment regarding the comments that you were just that I think that a lot of this comes down to not so much errors of communication, but errors at the cognitive level. So someone hasn't felt that something is important. Otherwise, they would have communicated. They would have made a different decision. There would have been an alternative strategy, perhaps to the intensive care for the radiology department rather than the general ward. So it's decision-making, cognition, a realisation that something needs to be done in a certain fashion, and then communication. That's kind of the process that should occur. I haven't answered your question, sorry.
No, that's pretty standard. Santosh, I mean, these sorts of communication issues, this is a complicated case, and it's often in an area where not everyone's an expert. And people are going to have to manage it along the way who are perhaps not all that experienced in some of the issues, or even, in this case, even the diagnosis. I mean, how do we go about making sure that we call out when we actually are not sure what's going on?
That's a good point. This is actually quite, I was just looking at this case and thinking this is actually quite a tough case to manage in intensive care. Here is a patient who has come back from theatre, who's intubated and ventilated, who's on hemofiltration, who's being dialyzed, and on a little bit of vasopressor support, and they say the lactate was a bit elevated. Now, if the gut was getting ischemic, the patient will not tell you that I have pain. The patient is intubated and ventilated. The patient is being filtered, so creatinine will not go up. What are the two indicators that will tell me that the gut is in trouble? The inotropic support would go up and lactate would go up. Now, in the middle of the night, we don't know how much of that happened in this particular case. As if I was leaving, I would have been more worried about bleeding. Patient had been given urokinase, patient has just come back from theatre, and if the vasopressors went up, the first port of call for a junior doctor would be to think, is he bleeding somewhere? So I think there was a cognitive dilemma here, and they were struggling to find it, and I don't think they actually got a hang of what was happening. It only when you do that can you escalate it or communicate it if you know things are going wrong. But I think at this point, if they did recognize that things were going badly wrong, I think they should have started calling their consultant in and saying, hey, can you come and help us out with it? And then the consultant getting a scan and everything else. But I think here they didn't even pick that the patient was getting worse.
Glenn, do you want to share with us the assessor's reflections? So, I mean, it's sort of brought out most of the points, but look, I wondered if we don't have any questions from the audience, can I just take up the point you made, George, in your opening address, and I'm interested in what the rest of the panel thinks about it, because I think it's really important. This business of admitting when you don't know or you're not sure, and it goes down to lots of things. I mean, I've sort of increased my activities at the Royal Adelaide, and I have to tell you, a whole lot of the acronyms they use at the Royal Adelaide I've never seen before. They describe certain units, certain behaviours, all sorts of methods they use, not sort of strictly physiological things. And, you know, I've made a habit of always asking what they are. And you can see around the room when I ask, half the people get that sense of relief on their face because they had no idea. They've been going to meetings for years. So do you think we should try and start a culture? It ought to be started by the heads of the units and the consultants on the units, not by the junior staff, of actually saying, when they don't know, I don't know what that means. I am asking you this.
Well, I think, yes, we must do that. But how we do that, I really don't know the answer to really fail, because I know 2 anecdotes that illustrate the fact that in my own communication to the subordinates, I had obviously not to convey the importance of what was on about. They didn't have the front to challenge me or to challenge other people that were seniors. In the case of the nurse, the instructor put the tube in place. She was wanted to take the tube out by my fellow who was her superior, and so she just simply implemented the instruction. Saying, I'm sure that's right, but I'm proving that those was the wrong thing yesterday, and this was the instruction, so now she should check with him. How do we change the culture? I guess I'm interested in perhaps hearing Julius how to change the culture that could lead to preventing that sort of thing happening.
In 2010, I was just upstairs here with the team from my hospital doing Team Steps, which was a fantastic program which talked about all the things we talked about tonight, about empowering people to speak up, escalating, checkbacks, handover, ISPA, all those sorts of things. It was a fantastic program, and it died. And I sit on a number of review committees, and every month I seem to feel like there's a communication problem here, and people haven't been empowered to step up. And I've asked about Team Steps, and I keep getting told that it's fallen out of favour with SA Health, and it's being remodeled for Australia and other questions like that. So that was my first point, is anyone familiar with the Team Steps program and where it's going and what's happening to it? And the second thing, just from Guy, where you're saying you as junior consultants, do you think that they're an area of danger? I find that there's these interesting graphs about confidence and competence, and as you go throughout your career, when you're junior, you know nothing and you have no confidence, and so you're relatively safe because you refer everything elsewhere. And at the end of your career, you know how much you don't know, and so you're also quite safe. But there's this area, and I don't know whether it's senior registrars or junior consultants, where people can get outside of their competence area by being overconfident. So there's two questions there. One's about Team Steps and the other's about junior consultants and what we can do.
Agreed, Ben. Fabulous program, and certainly tools such as checkback and challenging when you can see that someone is obviously doing the wrong thing. There is actually a process on how to challenge people, and all of us that went through that training, basically committed to if people used those strategies, that you would stop and you would listen, because we know that nursing staff will raise issues, junior medical staff will raise issues, and we've got lots of cases where there's been terrible outcomes for our patients because the people they were talking to either didn't hear, didn't interpret the information correctly, or chose not to engage. So absolutely, I think it needs to. There are a number of units, and I know the intensive care community have still the morning huddles in all of the intensive cares, as far as I know. That is just everyone stands there, including, can I say, the ward clerks and the cleaning staff and the orderlies who will be doing the patient transfers. They are part of that discussion to plan the day and introduce who's in your team. In the surgical field we have where we do our patient, we stop and do our patient checks when the patients arrive now in theatre, and that's led by our surgeons, and that is part of Team Steps. That came out from there, works very effectively, and that is actually identified, especially when we've had the whole left-right thing, which seems to come up. We've actually had near misses that have been identified at that point, so our patients haven't had an adverse outcome. Really need to reinvest in it. If anyone wants a great little book, there was a book from Team Steps on a colony of penguins. I can't remember the name of it. Can you remember? The Iceberg's Melting. Yes. Fabulous book, really quick read. You can identify members of your team in that book, and you actually get a bit of a giggle as you go through, because you can actually pick who the behaviours belong to. But I really recommend people read that, because the message in there is to stop and to listen and to take the time to actually think about, am I doing the right thing? So,
Well, perhaps on that extremely positive note, which it is good, I'd sort of like to thank the panel. Glenn, shall I handball back to you to wrap up proceedings?
Yes, thank you, Guy. So can I thank the panel very much for the contribution, Guy, for his guidance to the panel. So you can show your appreciation here